Remember I said to all of you, is there any pharmacists out there? And no hands went up. Well, a guy showed up. Here's my favorite pharmacist from Congress, Buddy Carter.
Thank
Buddy,
you.
great to see you.
Good
of
to
course,
see you.
Congressman of Georgia. And we're going to discuss the pharmacist in the room. A pharmacist's view of Congress, of course, Buddy Carter's from Virginia. He is the chair of the House Committee on Energy and Commerce Subcommittee on Health. So you're right in the ecosystem. We're talking about the clutter of American healthcare, how to design it. We've had, basically every corner of the political aisle, the medical aisle, the pharmaceutical aisle, patient advocacy groups, coming in to share slices of life in what has been a kind of a marathon day discussion on how we can all kind of collectively improve and move on. And I think one of the comments we had someone from the Healthcare Distribution Alliance talking about pharmacists on the front end, and the fact that you could actually kind of look at health reform in a way that you empower some of those pharmacists with some things that would take some burden. But I'd love to get I don't know how long you're going to be in Congress. You're going to be a pharmacist again someday?
I don't know about that. I still have my license.
Do you?
I'm certainly not giving it up for this gig.
So you could deal drugs in Congress.
Well, yeah, but I have to pay taxes. So
okay.
Make sure we understand.
But I would love to get your radar screen, in my view of sort of as you look at what our priorities ought to be. A lot of today has been around how do we get the system to continue to innovate, to make strategic leaps, not be satisfied with the inertia in the system. Mm-hmm. I would love to get your input on what you think the things are broken that we need to fix.
Well, first of all, the drug supply system and the drug pricing system is something that I've worked diligently on since I've been a member of Congress. Quite honestly, and I'm not patting myself on the back, but when I got here 12 years ago, I would say PBM, and people would look at me and, what in the world are you talking about? They didn't know what a PBM is, or was at that time, but they know what it is now. I can assure you of that, because it is, it's the middleman that really brings no value to the healthcare system at all, but causes prices to increase. And it's something that we've been working on, and that I would like to think, and I do think, that we have made some progress on, and we've made some real reforms. I would be remiss if I did not thank the administration for what they've done with the most favored nations. This is a tricky area, and I hope everybody understands this. Listen, I practiced pharmacy for over 40 years. I started when I was 10, by the way. But anyway, I practiced pharmacy for almost 40 years. And I can tell you that I saw nothing short of miracles as a result of research and development. And we do not want to stifle innovation, and nor does the administration want to stifle innovation. And I can assure you of that. But we got to make sure that we don't do that through the most favored nations. And I think the administration has really hit a sweet spot with that, and that they're not causing a decrease in innovation and a decrease in research and development. I think there's still incentive in the capitalist system that we have for drug companies to invest in research and development. I give the example all the time. When I started practicing pharmacy in 1980, if you were diagnosed with hepatitis C, you were going to die. That's all there is to it. In 1980, if you had hepatitis C, you were going to die. Well, now we can cure it with a pill. I mean, just stop and think about that for a second. That is phenomenal. We can cure it with a pill. And that is really something that we need to continue, that kind of innovation. I mean, people are living longer now, and people are living more quality of life that has improved as a result of pharmaceuticals. And I'm very proud of that, very proud of my profession, and very proud of the pharmaceutical industry for what they've done to contribute
on this MFN thing, though, are you hearing from companies that are in the kind of broad basic science R&D that think it's good for them? I think most of them are telling me there's some problems with it because, they understand the dynamics and the math, but, the math is, shouldn't the other folks, as opposed to cutting the prices down here, shouldn't the folks on the other side raise what they're paying, because at some point there's going to be a squeeze on those dollars in R&D.
That's exactly right. And, I can give the example, and pardon my simplicity here, if you will. I'm very thoroughish. But, we got American prices up here and foreign prices here. And what needs to happen is more of this. We need to bring the prices over here down, but they need to bring them up over in the other countries as well. There are a number of factors that influence that. One of the factors is the is that not all drugs are available in other countries. In Australia, for instance, only about 70% of the drugs that are available here are available in Australia. That's a problem. And in other foreign countries, it's very similar to that. That's one of the things that we have to address. The fact that they are subsidizing a lot of that. The governments are subsidizing a lot of the drug costs. That's another problem. So, I do applaud the administration because I think they're taking the right approach in the sense that they are telling the American companies and the American manufacturers, yes, we need to bring these prices down over here, but we're going to help you with some reforms in the other countries as well, and I think that's going to help.
You and I have talked about the real challenges and gaps in the kind of crappy economics of rural healthcare, and like everything. I mean, people try and pretend there's not contraction. There's contraction going on there. It's just much more complex for people. When I was talking to our friends, some of our sponsors this morning at a breakfast, and they're obsessed with accessibility and reaching people, but they said, it's tough sometimes out there, both certain communities, but also the rural-urban divide. But, do you have any magic solutions for that?
Well, one of the things I would mention is this. Look, at the end of the day, whether you're Republican, a Democrat, or independent, we all want the same thing when it comes to health care. We want accessible, affordable, quality health care. Whether you're Republican, a Democrat, or independent, it doesn't matter. You want accessible, affordable, quality health care. We all want that. Accessibility is something I'm very concerned about, because, particularly in the rural areas, because we're having more consolidation in health care. Particularly, that's really one of the things that has happened to increase drug costs is the consolidation, where you have the consolidation of the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. You know who's the largest employer of physicians in America? United Healthcare. United Healthcare employs about 9% of all physicians in America. Now, there's nothing wrong with working for United Healthcare, but an insurance company is the largest employer of physicians in America. And you've got the top 3 PBMs that control 80% of the market. You've got CVS Caremark, you've got United Healthcare, and you've got Express Scripts, Cigna. 80% of the market there. We were in a meeting. It wasn't a hearing. It was a meeting of the Energy and Commerce Committee, and we had the CBO, the Congressional Budget Office, in that meeting, and we had the director, and we had 20 staff members. And I asked them the question directly. I said, give me one example of where consolidation in healthcare has saved money. They couldn't give me one example. Now, I'm not here to bash on the big boxes and the big companies, but at the same time, competition. That's what's going to. I want to give you what I think is a good example. 2 of the most significant reforms that I think have happened in drug pricing, aside from what is going on with most favored nations now, 2 of the most significant things that have happened. One was during the first Trump administration, I was able to get a bill passed that ended the gag clause. What happened was, when I was practicing pharmacy, if I had a contract with the PBM, that PBM would have a clause in that contract that said that if the cash price was less than the copayment, I could not tell the patient that, or I'd be kicked out of the network. Well, obviously, I couldn't afford to be kicked out of the network, so I couldn't tell the patient. We did away with the gag clause so that now the pharmacist can tell the patient, hey, you pay cash for this, it's cheaper than your copay. That was one of the most significant things that happened in drug pricing. Another significant thing that happened with drug pricing actually happened in the retail market. And that's when Walmart came out with the $4 prescription plan. I remember I was practicing pharmacy then. I had my pharmacies, and they came out with this plan that you could get a 30-day supply for $4. You could get a 120-day or 90-day supply for $12. I bowed my back. I said, there's no way I'm doing that. I can't even buy it that cheap. Well, guess what? A week later, I was doing it. I had people leaving that drugstore going to Walmart. And I called my wholesaler up, and I told him, I said, look, you got to do something. You got to help me here, or you're going to lose a customer. And we did. We brought the prices down. That's how competition brings prices down in healthcare. And those are simplistic examples, but at the same time, they're real examples. And that's what we need, is more competition in the healthcare room.
You know, we had Dave Schweikert here this morning as our opening talk. And he made something, I don't know if it's true, but he sort of made an interesting comment about, you know, telehealth and the importance of telehealth and technology and video, which I know you have been supportive too. But he said, you know, what's threatening it, he said, are, you know, the real estate crowd, you know, with urgent care centers, you know, trying to undo this. I had no idea if that tension was out there and existed between sort of bricks and mortar care centers versus what's going on. But I do know that one of the big new innovations, you know, that's happening, the evolution, is that, you know, pharmaceuticals to consumer requires a kind of video connection with a doctor. Telehealth is kind of built in and baked in. And you also know, in terms of achieving health, you know, a lot of people just want to make it easier. They don't want to drive 60 miles to see a doctor or something like that. What is the status, even with pharmacies, you know, interacting with them, what is the side of the digital health, telehealth side of that? How wobbly or stable is that now? Is it really threatened?
I don't think so. Look, you know, before the pandemic, we were all talking about telehealth and saying it's a wave of the future. And then the pandemic
future got here.
And all of a sudden, telehealth was an integral part of the healthcare system, became an integral part of it, and it remains an integral part of it. And it is key in providing healthcare, particularly in rural areas, for a number of reasons. Access, we talked about, remember, accessibility, affordability, quality, access. It increases access to healthcare, and that's very important as well. Not only that, but keep in mind that we've got a number of shortages of healthcare professionals, particularly of specialists, psychiatrists, whatever it may be, whatever discipline it may be, and with physicians, you have a shortage of that. This is another answer of that and helps us in the rural areas in particular. So I'm a big fan. We were able to get that as part of the Consolidated Appropriations Act of 2026. We got the changes that were made during the pandemic to telehealth. We got those extended, so I was very proud of that, and I think it helped healthcare.
We're going to do this every year, buddy, and so I want you to come back a year from now. But if you were to kind of look at the healthcare system and say, wow, in a year I will want this country to have solved X problem, what would it be?
I would think it would be drug pricing. And, you know, that is just, remember, I practiced pharmacy, and I was the one who had to go to the counter. I was the one who had to tell the senior citizen how much the medication was and watch the senior citizens make a decision between buying groceries and buying their drugs. I was the one who had to go to the counter and tell the mother how much the antibiotic was for their child and watch her in tears as she tried to figure out how she was going to pay for that.
Right.
And that was my goal in coming to Congress and serving on the state level and on the federal level is to help those people. These are real life people, as you just heard. You know, this is not just some example in a textbook. No. These are real people who are suffering out there.
That was powerful. Well, buddy, it's always great to see you. Thank you so much, as always, for coming out for some important conversations on health. Ladies and gentlemen, Representative Buddy Carter of Georgia, thank you so much, sir.
Thank you.
Thank you.
Always
Take care, my friend. Thank you.